who's a medical doctor practicing in the United States, and she is specializing in dermatology. And today's seminar actually just on a illness that I hardly know how to pronounce. Psoriasis, is it correct? Okay, I learned it from her because I see patients having this kind of problem, but in general, I have to claim quite a bit of ignorance in the area, which is to my advantage perhaps. I don't need to know about it too much. But as a social worker, actually, I should also be knowing it more because maybe there are a lot of patients who are actually suffering from more serious or less serious cases of this. So today we are very privileged to have Dr. Untitled Chapter, who is the fellow at the Department of Dermatology, University of California, San Francisco, to deliver the seminar with us. And we are even more fortunate to have Mr. Gary Lai, who is the chairperson of the Hong Kong Psoriasis Patients Association. This is actually a new association. It started just, I think, a few months ago. And then we have very competent Mr. Gary Lai, who is working very hard to help people to have more understanding of the challenges and also the issues related to this illness. Okay, and hopefully we can be educated and then we learn more about some of these challenges and what are some of the ways that can be done to better handle it. Okay, our seminar is generally rather informal. So in terms of time, we can talk up to close to 2 o'clock before we hand over the room to another class. Okay, so how about Dr. Lam, you deliver your talk for half an hour or so, and then we'll hand it over to Gary, and then you share some of your views and experiences from the patient and also the patient group's perspective, and then we can open to the floor to discuss. Okay, so how about I hand over the time to Dr. Lam.
Thank you for having me here today. I'm going to put my mouse right here. My name is Argentina. I'm from California, San Francisco, and really appreciate Dr. Zhang for inviting me over here. And today's topic is on psoriasis. But before I begin, does anybody know someone, a family member, friends, a patient who has psoriasis? Oh, pretty good amount of people. All right, good. Okay, so let's begin. So before I begin, I wanted to talk a little bit about the history of psoriasis, give you a little bit of historical background. Psoriasis was actually first described as a skin disorder by a Greek physician called Galen back in the 200 AD. The Greek origin psoriasis is origin from a Greek origin. Psora means itch, and ISI, psoriasis, isis, it actually means condition. So if you put it all together, it literally translates psoriasis means itchy condition. And back in those days, there was one point in time that people do think that psoriasis is contagious, just lumped together with people who have leprosy. People back then in the medieval time actually carried something like a little clapper or a little bell. And so whenever they come by, they will ring a bell and people will get away from them. So social stigma was the issue even back then. And to throw in a little bit of historical aspect, back in those days, they don't really understand psoriasis too well. And they thought that psoriasis was actually due to poor nutrition, infection, hygiene problems, or allergies, which we know that are not true, because psoriasis is a autoimmune mediated disease, especially in Th1 and Th17 aspects of the pathway. And I just put this in because I thought it was relatively interesting, where they tried different remedies in the past, before the 19th centuries, including cat and dog dung, meaning feces, fresh oils like goose oil, and even onion mixed with sea salt and urine. Probably did not work too well for them. So the goal of my talk today is to bring awareness, better understanding of psoriasis, and promote awareness to our society so that people will know a little bit more about this disease. And my presentation is going to break it down into 3 parts. The first part is on clinical and psychosocial impact of psoriasis. Second is we're going to talk about the associated comorbidities in psoriasis. And lastly is the treatment options that are available. So let's begin. Psoriasis, as I alluded to earlier, is an inflammatory autoimmune disorder that can come and go with time. Lesions often come back, and when they do come back, they usually come back at the same place that they had it before. Generally affects 2 to 3% of the world population, and many of you have seen it before. It's really a very thick silvery plaque scales. They have different type of psoriasis. Some of them has plaque type. This is considered a plaque type, but they also have gut type, meaning all looks like raindrops. Pustule type looks like there's little pustules, and erythrodermic one, all the skin looks really, really red. But majority of type is plaque, which accounts for 80% of the psoriasis. So this is what we're going to focus on today. Other ways of psoriasis can appear is in the axilla or in other private areas on the folds of the skin. That is, very unsightly, especially people who do have want to have an intimate relationship with someone. Another way that can represent is also having pitting nails. Pits meaning like if you eat some fruit inside the pit, it looks like a little dot or like a little pinpoint into the nails. Despite how ugly it may look, it is not contagious. And so aside from the disfiguring appearance, it also has symptoms that are associated with psoriasis. One is pain, which is reported in 42% of the psoriatic patients, mostly on the head and the scalp and the hands, largely be due to the fissures. When they itch, they scratch, and it fissures, meaning there's a break of the skin, it's causing pain. And then itching, of course, in majority of the patients, 70 to 90%, it varies in intensity. So it's rated as one of the most troublesome symptoms, as you can imagine, with the appearance and then the itch and the pain, all of which can affect one's physical, psychological, and occupational well-being of someone. In fact, Rapp et al. Published a paper in JAD in 1999, and what he did was he compared different groups of patients with different medical problems. And psoriasis has always been known as mainly a skin disorder, but nobody really paid much emphasis or attention to it because they say it's just a skin disorder. So Rapp et al. Actually published a paper to tell us that psoriasis can cause as much disability as other medical illness. By filling out this form, SF36 is just a health survey asking the patient how much this disease has affected them, both physically and mentally. And so as you can see, the blue one is the psoriasis, and the red one is hypertension, post-MI, meaning heart attack, congestive heart failure. The lower the score, the worse it is. So psoriasis is pretty much around the ballpark, very comparable to other major medical illnesses. So here comes my second part of the presentation, which talk about the associated comorbidities in psoriasis. So psoriasis is not just a skin disorder because it has other comorbid conditions. And here are some of the few ones. Hyperlipidemia, cholesterol problems, hypertension, depression, diabetes, heart disease, that includes cardiovascular disease as well as heart attack, psoriatic arthritis, and obesity. These are just some of the few. There are a few more in there. So in this paper, it just shows us that psoriasis patient has an increased risk for heart attack. If you look in this graph, people who are younger in age and have more severe psoriasis, which is dark, bolded, filled in plaque, has a higher likelihood of having heart attack as compared to people who are older in age and has mild psoriasis, which is the white little balls right here. So people who are younger and have severe psoriasis have higher likelihood of having a heart attack. Why that is so, we don't know yet. But we just saw there's this trend. The other things that for patients with psoriasis has an increased risk for is metabolic syndrome. Metabolic syndrome is just a group of syndromes with high cholesterol, high blood pressure, impaired fasting glucose, and abdominal obesity and abdominal girth. If you have 3 out of the 5 of these symptoms, then you have metabolic syndrome, which also can contribute to heart attack and cardiovascular disease. So if you look at the graph right here, the prevalence of people with psoriasis have 40% chance of getting metabolic syndrome, and then versus 24% with people who do not have psoriasis. So it's actually the prevalence of metabolic syndrome is higher for people who have psoriasis compared to the ones who don't have psoriasis. Not surprisingly, given the psychosocial aspect of the disease, people tend to have higher risk of psychosocial impact, like depression, anxiety, and suicidal rates. In here, similar to the people who have higher risk of heart attack, seems like the more severe the psoriasis, the higher risk of depression people can have, which is 1.7-fold compared to the general population, 1.45 times the increased risk. And one of the ones that you people might already know is psoriasis is closely linked to arthritis, a particular arthritis called psoriatic arthritis. This one affects partly 30% of the patients who have psoriasis, and usually the skin symptoms precedes the joint symptoms by at least 10 years. What you find in the distinctive features is the swollen joints, or we call it sausage digits because it looks like sausage. That all caused by inflammation. You can also see that there's inflammation at the insertion of the tendon, which is the Achilles tendon, where it's really swollen right here. So when you're examining the patients, you touch the hands and then the Achilles tendon, you can get an idea of what kind of arthritis they have. People with psoriatic arthritis also have bony destructions and erosions and bony changes over time. So those can be irreversible. Once you have bony deformities, those are irreversible, versus the skin psoriasis is reversible as long as you treat them correctly. So people might think, well, what is the relationship between psoriasis and all these comorbid conditions, hypertension, diabetes, cholesterol, depression? Is there a link to them? Why is it that this psoriasis group of patients have higher risk for all these comorbid conditions? So now the thought of this right now, they're thinking that there could be a link to inflammation, meaning all these conditions are related to some kind of chronic inflammation that link them together, give them the higher risk of developing these disease. And to further test this point, this is Dr. Mehta. Him and his research group actually used this PET CT scan combined and scan people to look for metabolic activities in the tissue. And what he found was when they scanned these two people, this is the control, person without psoriasis, and this is a person with psoriasis. They noticed once that they scanned that there is inflammation systemically. The ones that are light up, meaning gives an idea that it has inflammation occurring in the area. So you can see that there is blood vessels that are highlighted, and you can see that there's skin on the skin that's highlighted. You have seen the liver. So it just gives an idea. Maybe psoriasis and problem psoriasis is not just a skin disorder. It's involving more organs. So now brings us to the third topic of my talk is the treatment of psoriasis. Thank goodness to technologies and research, we no longer have to use the old remedies of the past. Current treatments actually involves many different ones, mainly topicals, orals, phototherapy, where you can go into a light box, and biologics. Now this is going in the form of increasing in intensity besides the use of cyclosporin. So giving so many options, how do you know what medication to use? You have so many options. Well, I think this is, it depends on the individual. Their risk factors, their history, and how much the medication costs. Also depends on how much body surface area that are involved. 1% of the body surface area is 1 palm of the patient. If you have 3 to 5 palms all added up together, that is you have moderate psoriasis. If you have less than 3 palms, you have mild psoriasis. But if you have more than 10 palms added together, then you have severe psoriasis. Then you have, it also depends on how much symptoms you have, where it's located, how thick is the plaque, do you have joint symptoms, and what's the patient's quality of life. Patient can have very little small amount of psoriasis, but their quality of life can still be awful. So then one might want to question, since they're kind of linked together, questionable whether it's due to inflammation or not with psoriasis and the other comorbid conditions, one might question whether if treating the psoriasis would actually help the other comorbid conditions. And so we don't have a clear answer yet, but there are some paper I want to go over that maybe can lead us to the right directions in the future. So one of the papers is by Dr. Jason Wu. He is actually a dermatologist at the LA, Los Angeles Kaiser Permanente, which is a huge HMO facility. So they actually did a cohort retrospective study looking back at the patients who have psoriasis, have the diagnosis of psoriasis, and he wants to know people who had topical, separating into 3 groups, people who had topical treatment for psoriasis, people who have oral and phototherapy treatments, and the 3rd group is people who have biologics, which is immunomodulator. And he wants to know which group has the lower risk for heart attack. And what he found was that people who had biologics had a significant reduction in heart attack risk incident rate compared to the one who only had topical medications. Versus the people who had biologics is also have a slightly lower risk of heart attack rate compared to the one who had oral or phototherapy, but that is not clinically, or that was not statistically not significant. So to kind of summarize this, people who have psoriasis who had biologic had a lower risk of heart attack compared to the ones who only had topical treatments. And it's debatable whether the people with oral and phototherapy also has some good effect. We don't know why, we just see a trend. So you cannot really say that it is the biologic that actually helped reduce the MI. Now another paper that is also written by Dr. Alice Gongiep, and she's also a dermatologist. It's to kind of summarize that etanercept, which is also a biologic, is a TNF alpha inhibitor, actually can improve signs and symptoms of both psoriasis and psoriatic arthritis. Moreover, it can also inhibit X-ray progression of the psoriatic arthritis. So you know how in the earlier point where people who have psoriatic arthritis can progress to the point where there's no return, like it's irreversible. Giving this drug, they have noted, and they've done like clinical trial studies, they compare the people who had biologic for like etanercept versus people who did not have etanercept. In 24 weeks, they noticed in the X-ray that there is a halt in progression. So this is a very good, important findings. And then lastly is a paper that was written by my boss, or in our center, and he wants to know how does treating psoriasis help with the psychological well-being. Well, to no surprise, if you improve someone's skin condition, we would expect that their psychological well-being will also improve. So basically, people had the treatments for the psoriasis, and we enroll like 33 patients. All these lines represent patients. A PASI score is a physical assessment of psoriasis. So how well you appear is through PASI score. And in week 0, you notice the higher the PASI score, the worse the clinical clinical exam is. And as you go to week 24, all the PASI scores came down, meaning you have better clinical outcome in terms of skin. And they also did a PGWB scores, which is a survey to ask for patients' quality of life in terms of their, psychological well-being. So they did it before and after. Before, the score is low, and after, their quality of life, psychological well-being has improved. So this shows the point that effective treatments in psoriasis is correlated with positive psychological well-being and physical improvements, which is something that we have already expected. So in summary, psoriasis is a severe debilitating disease that can affect both physical and psychological impact. The current data supports that there is a existent or associated condition, comorbid conditions, with psoriasis. And some studies have suggested that if we treat psoriasis effectively, not only does it improve psoriasis, it can also help alleviate some of the comorbid conditions such as depression, psoriatic arthritis, and etc. But that being said, I think there's still more studies that needs to be done to clarify the relationship between psoriasis and its comorbidities. Is it really linked by inflammation, or could it be something else? And which comes first? Is it psoriasis first, and then hypertension later? Or is it hypertension first or psoriasis later? We don't know. So the relationship's still under investigation and under research. But I think it is very important for people who have psoriasis to be aware that that there are possible potential comorbid association with their psoriasis, and that they should make healthy lifestyle changes early on in terms of preventing obesity, diabetes, and high blood pressure, and also seek appropriate effective treatments. That psoriasis patients don't really need to be treated with just topicals. There's many options available outside, depending on who they go to. So, and that's it. I wanted to thank everyone over here. Here is my boss, and these are the people that I work with over in California in my center. And I also wanted to thank all the people in Hong Kong who have supported me in this presentation. And Hillary Clinton once said that it takes a village to raise a child. So I think it takes this village to make this presentation happen. So I just want to thank everyone for all their time. Any questions? No? Okay, so.
Well, how about we pass the time to Gary first,
Yes.
and then he can respond as a long-term patient. But actually, he is helping now to improve the quality of life of people with similar experiences. So he has really stepped out to help them. We are doing fine with time, so Gary, you can take your time.
For the presentation,
Alright, is it the one before mine?
我有帶佢，
你有冇？
我有帶
如果唔係我有，你有係嘛？
minutes. Sorry. Yeah. Đây vậy này. Okay, maybe I just talk with you freehand. My name is Gary. I'm glad to be here today. I have psoriasis for more than 20 years already. I have psoriasis since 20 something. Now I'm 40 something, and now I have 20 years experience in that. I'm lucky to be here today because today here in social work department, most of the time I go to the primary hospital and the doctor asks me questions. This time there is a special occasion here to stand in this department to talk with you, and I will present in from a patient point of view to talk my feeling, my family relationship, and how I cope with it. And finally, I will talk about we as a patient to set up a patient support group first, and we want to organize and we want to work together with the patients.
Or if you have any questions or comments, you can begin to take some questions while they are trying to set up this PowerPoint. Yeah. Or have you actually started some of your presentation already? Then how about you continue?
Okay.
Yeah.
Okay.
Yeah.
When I first have my psoriasis since early 20s, the first question come to me is why me? Yeah, it's a shock to me. I don't know how to deal with it at the very beginning. Besides ask myself this question, I asked my parents, do they have similar symptoms before? And later I realized that my mom has this question, my mother's fathers also have this question, and I realized that it should be a family history, and it so happened that I have this problem. And I checked with my siblings, my elder sister and my younger brother, do they have similar symptoms? No, they don't have. They are very healthy. They have no this kind of problem, and only me. Okay, then I have to think. Okay, when the problem come to me, how do I solve? Okay, by that time I just graduated from the university, and I first start my first job in a computer company. As you can realize, you can understand the stress level is quite when you see the new boss, the new colleagues, you have to, in a new environment, working environment, I'm sure everyone think it is a stressful situation, and I believe this is the main reason I have my skin flare in psoriasis. Yeah. After that, by that time, I believe I have more than 70% of my body covered with the psoriasis flare. And at the very beginning, I asked. That's good. That's good.
Thank you.
Okay. As my title says, it's more than skin deep. Just like Argentina just say, this psoriasis problem is more than the skin problem, and that's why I use this title, more than skin deep. in the following 15 minutes, I think how when I first had the psoriasis, how I confront with this, and then there are some misconceptions and misunderstanding among the public of this psoriasis. And I will talk about my clinical trial experience. It is a little bit special, especially in Hong Kong. And finally, I will talk about the patient support group in Hong Kong. This is the first patient support group in Hong Kong. When I first come to psoriasis in early 20s, my problem have over 70% covered with psoriasis lesion. And by that time, I go to the general practitioner, the doctor. They say, oh, it seems to be eczema. So they give me the medication of the eczema to treat me. But the treatment is not very good. So I turn to the specialist in Department of Health. They diagnose me as the psoriasis. Then I go to the proper treatment by the time. And after I got the problem, the first question that come to me is why me? And I check the family history, and I realize it is me to face it alone. So by that time, I'm really upset. Depressed, hide away from the crowd. If by that time if my colleagues or the friends ask me to hang out after work, I say no to them, and almost all the social interactions with the public are gone off. I every Saturday, Sunday, I better stay home and not go out. Just stick my fingers on the keyboard only. Yeah, this is the way of life I was. And in terms of the family relationship, I should say it's really worse by the time. When I know, oh, this is my family history, I really blame my mother. Why you inherited me these genes to me? And I really have to quarrel with my mother over this issue. And family and social interaction is almost gone off. And it is a vicious cycle, as you can imagine. The illness, my stress, make the psychological impact even worse, and there's a stress behind this, and the stress it can induce my immune system even worse, and even when the immune system worse, my skin condition is even worse. You can see the relationship here. And by that time, 20 years ago, you can say I'm a kind of a 宅男, or people who hide away and not try to go out, this kind of person. Well, for a while, I think for more than 3 months or 4 months, I have this experience, and I keep on asking me my question. Okay, should I stay on this stage, this kind of situation for a long time? How about my next 10 years or 20 years? How to deal with it? Should I suicide by the time? No. Should I go out? Yes, I should. Then I realized I have to find the proper treatment. Yeah, and rebuild my family relationship. Yeah, there are many common misunderstanding about the disease. It is called obesity, but it is not really about it's not contagious. We are human, not cow. And I think just happened that psoriasis is very stubborn, and it is really hard to cure. That's why they call it's like the skin cow, and which is really difficult to treat. Yeah, it is the Chinese Cantonese convention here. Yeah, and
No pain just means very tough and rigid and hard to manage. So
Yes,
so it's not necessarily talking about the cows or whatever.
yeah,
but it's just referring to very tough thing to handle.
yes, yes, exactly. I also face the problem. People say when I talk to people, unsick band or vaccine, the first thing they come to their mind is it contagious? Is it catch to them? I don't have this disease. Is it spread to them easily, like the air or whatever? This is the first reaction they have. And I also have the lifestyle story about me. I go to, I prefer swimming. I go to swimming pool. The swimming the lifeguard guard no, I have the psoriasis problem. But other swimmers, those people who pay in to get in the swimming pool, they don't know. So they point out my case to the lifeguard. Oh, say this guy have the skin problem. If he go to the water, he will contaminate the pool of water. So the swimmer asked the guy, take me out, advise me to go out, get me away. Yeah, and this kind of feelings, I always have this story, and you can say it is unfair, but to me, I think it is discriminated. You and I are both human, but so happen I have the skin problem. You can be away. Why? Yeah. And in our most of our patients also have the public transport experience. When they get to the NTR, the other public transport, and especially in summer, we usually take the long shelves clothes to cover up. Okay, once we hang up the NTR stand post, we expose the skins, then we can see the lesions there. Okay, the people will walk away. Yeah, and well, we always joke among ourselves that okay, in MTR we are very lucky. We pay the same amount of money, but we have more space. We can have seats. And another problem is is related to our occupation. Some patients need to see their clients, need to see their boss, or interact with their colleagues. Their boss or their clients see their problem, their skin problem. They don't want to do business with him or carry on to work with them. Then this is another problem. This problem, the medical hindrance. In Hong Kong, most of our patients go to the public sector. Private sector we still have, but the proportion is not as high as in the States. So in the public sector, we see the dermatologist, and we always give the ointment, give the oral administration, the drugs. But finally, we cannot make a very good treatment at the end of the day. And we heard some government officials say, "Oh, psoriasis is not fatal; it only affects your skin. It is not life-threatening." So they not tend to put more effort on us. This is the real situation, real case. Okay, well, in Hong Kong we have this treatment. I have go for most of them. Very lucky. In Hong Kong, this psoriasis is a skin problem, so we have the steroid ointment at the very beginning. But this treatment is not a very good option, especially for the severe case. In public sector, we cannot have enough amounts of ointments, and the next we have a long treatment interval in between, 3 months to 6 months, depends on the severity. But the Department of Health cannot give you all the way 6 months ointments. Yeah, so we still have some unmet demands. Okay. The second one is the phototherapy options. This one is very time consuming. The patients have to visit the clinics every single week, 2 times. For the people like me at this stage, we have to work in the office, so this option is not viable. And then the next option is about the oral administration drugs. I tried the methotrexate, MTX, and right now I'm using the retinoid, the vitamin A. Both have the side effects. They're very effective. MTX have the side effects of the liver enzymes. The liver enzymes will elevate it quite high, and the side effect may be the liver problem. Okay, retinoid is another treatment, but the side effect may be the skin will turn thin, yeah, and the mouth damage, something like that. Yeah. And the last one is the biologics. It is quite advanced, and it is at this stage is quite effective, but the problem is the side effect. There is still side effect, but we do not know yet. But we know for sure it's very expensive. Yeah. Most people cannot afford it, to be honest, in Hong Kong. I'm a very active people. I try to treat myself in a better way, so I participate the clinical trials. 6 or 7 years ago, I participated in the Queen Mary Hospital. In Hong Kong, it's a very strange place. When I talk about clinical trials, our patient's first reaction is, "Oh, you are a skinny pig. How come you try to do this?" There's no guarantee because the treatment option is very different. We have to go through the washout period. You will randomize between placebo and the real treatment. So the patients are very resistant against the clinical trials in this area. But so often I try it, and some of them are very effective. The first one I try is the traditional Chinese medicine versus methotrexate. It's the Chinese and the Western comparison. Yeah. This one I'm lucky. Traditional Chinese medicine, I'm in the placebo group. We can see the effects. Okay. The second one is a biologics, which is by that time was phase 1A, very early stage. But the treatment is not very good at the end. We can only see 30% improvement. But the international standard is 75% is the passing rate. The third one is the steroid, it is a market available options. This one is very good. It's more than, to me, is more than 80% better off. And the last one is the Jeffrey versus etanercept. This one is because we know the biologics, we need to inject or go to the hospital to IV inject in the infusion in the body. It is very time consuming and not very convenient. Jeffrey is a more convenient treatment, which is just a pills. we intake and every day, and we compare the biologics versus the pills. We see a improvement, but the improvement is not good enough to reach the international standard yet. Okay. Well, this is my story. I try to cope with this actively, and I try to stand up and face the public, and that's why we have the psoriasis patient group set up here. This patient group established last year in December. We want to provide the proper information to the public and the patient, among patients ourselves. We know patients are high away, they do not know the proper treatment, even they do not know there is public treatment in Hong Kong, public educate, public, how to say, 公共醫療
Public education, public
medical
public health in Hong Kong, yeah. So we are the one who provide the information, and people outside among our group are also ignorant about our disease. They still keep on using our vaccine, and they still think that it is contagious, and it is we are a special group of people. I want to tell them we are just common people. We are living together, and anything special. And another objective is it's very strange among the patient group. If someone stand up and share among themselves, the other people will follow. Now I'm the first one to stand up and try to speak out, and hope there is a spoiling effect. And advertising time, we will have a patient talk on 18 in MOT. Yeah, we will talk about the cardiovascular problem in Hong Kong. This is our first seminar, and sooner or later we will start another talks. Yeah, and we need your support. And as I say, beauty is but skin deep. Yeah, we are psoriasis. We are more than skin deep. Yeah. Thank you.
We are very privileged to have him to come here and share. And we are even more privileged to have Professor Cecilia Chen. She was actually the one who started the Community Rehabilitation Network, which has now so many branches. And nearly any long-term illness or short-term illness, you name it, they have a patient group. So our department and our colleagues have long been involved in things like this. And also we have a guest, Dr. Chan, who is the younger brother of our colleague Dr. Celia Chan, and he happens to be one of the dermatologists in Queen Mary Hospital. How about we also invite him to share a little bit before the few of us come here to take the Q&A time. So how about you sit over here for us? After hearing so much, do you have some comments to share with us?
I don't have much to share, but thank you for the opportunity. It's a pleasure to share with you, with other colleagues here, and also Gary. Gary is my patient, and he's a very good patient. He complied to our treatment, and he always registered to be in our trials. It's very amazing, because not, as mentioned by Gary, not many patients are really to take part in our trials, because in traditional Chinese, we were worried about being the guinea pig. We don't want to be in the experiment, because we're uncertain of what will happen in these trials. But we assure you, for all these trials, they're safe. And they must pass certain safety standards before they could be marketed or get into the university to do the trials. And Gary, of course, a very good patient. I must send my thanks to him, because he always takes part in our trials, and he's very active in the right and to the other benefit of all the other patients. And for the other things I would like to say about psoriasis in Hong Kong is that we are taking step by step for more. We protest to the government to have some more resources to help these relatively poor patients, for those with severe psoriasis. And Gary is helping us a lot in fighting with the government. It's very true that Gary mentioned to us that for many officials in the government, they say psoriasis is only skin deep. It's only something about the skin. It's nothing about the internal organs, and they do not see much importance about mental or psychological health. And so we fight for many years, since the years of my mentor, Dr. Yang, and then to me. And then we fight against the government to try to get some more resources for the government reimbursement for biologic treatments. As mentioned from these two talks, you will see biologic treatment is the latest or the more advanced treatment for psoriasis. And it really offers a good hope for many patients with very severe disease. But of course, this is very expensive. Of course, it is getting more and more cheap because of competition, but still it's very expensive. For your reference, in Hong Kong, I think, in average, patients will still have to pay about 7,000 to 8,000 a month, no matter which biologics you're going to use, because in the market there are 4 available biologics with different administration frequency. But still, you have to pay in average about 7,000 to 8,000. In the public, this is the so-called 成本價, the average price. But in private, you will even get an even more higher price because they will market that. And we do fight against the government and to fight for some more resources. And the good news is that we finally get the approval from the Samaritan Fund. Like many other chronic debilitated disease, we got the reimbursement scheme from our government since last year. But the bad news is still there, is that the criteria for getting into this Samaritan Fund umbrella is still very high. Number one is the clinical criteria. You have to be having a very bad disease, and you have to try many traditional old-fashioned therapy before you can get the biologic treatment. And secondly, of course, the financial constraint. You need to pass a whole list of financial assessment before you can really get this approval from the government. But I think this is the first step. And Gary and the group did help a lot because as we are making our protest to the government, they would like to listen to the real patient's voice, and they help a lot, and they step out to try to say their feelings to the government. This is very important. Yeah. And I think we are as the very few dermatologists who work in the public, I have the privilege to be in contact with these good patients, and we try to work together to try to arouse the public for their acknowledgement of this disease and to increase public education. And we hope we can do some more in the future. And of course, for the department like yours, I think we need your support for the psychosocial intervention for this group of patients, because we all know from local and global study, psoriasis do have great psychosocial impact, which often being neglected by physicians. And we are well aware of that, and we hope by the upcoming collaborations we can help them more besides the skin and besides physically or physiologically, they can have a better mental health. Thank you.
And actually, I also have to thank Dr. William Wong, because he is our colleague at the Hong Kong New Family Medicine, and we are coordinating this symposium today. And he is also making regular visits to the Hong Kong New Shenzhen Hospital. Do you have anything to say about, can you start to get people like Gary to say more from the patient's angle in your local and also Shenzhen kind of medical services? So, Dr. William Wong.
I think from my experience, Gary is quite unusual because we don't get to see many people of his age group come to visit us. At the government outpatient, we tend to have really older people, maybe in their 60s, who had this disease for nearly all their life. And the problem is they really tried many things, Chinese herbal medicine, different food, or different doctors, outpatient, dermatologist, and they very much given up. So they're very angry within themselves. On one hand, they just have to deal with all this discrimination, daily problems that Gary described. On the other hand, they try so many things, but none of them seem to last. I think it's the problem with the expectation. And that's something I think has not been dealt with comprehensively. So a lot of time is treatment, management from the disease perspective, but very little is done actually on the counseling side, on the psychological health, which I think the social health department will have a lot to contribute.
Okay, thank you very much. So how about Gary and Tina, would you like to take a seat, and then we are happy to take any comments or questions or whatnot. Okay, do we have any questions, comments, sharing from the field?
Well, actually, I'd like to ask Dr. Shen about the incidence. We understand that incidence of lupus, for instance, double that of the West. What is psoriasis then? Is it the same or is it different?
Well, we don't have a very exact figure in the past 10, 20 years. The last epidemiological studies done was in the 1970s something. But according to that study, it's about 0.2, 0.3%. It's actually tenfold lower than the prevalence rate in the Caucasian. Therefore, we would still want to say it is a bit lower than the Western countries. And this is actually quite true, because in recent 10 years, we got studies from the southern China, and they call the prevalence is about 0.6%, still fivefold less, fewer than the overseas countries in the Western countries. It's lower.
But is it largely genetic or?
Yeah, we think so. We think so. It's largely genetic. Yeah.
I actually have two questions, one for Dr. Leung and another for Gary. So my first question is I learned something new that is associated with metabolic syndrome. I think you've mentioned it, but I just wonder if there is any study actually which shows if we treat the psoriasis, would that make the metabolic syndrome better or vice versa? Or if we manage the metabolic syndrome better, would that affect the outlook of psoriasis?
That's a very good question. I think right now, in terms of biologic treatment metabolic syndrome, I don't think they tested on RA patients, rheumatoid arthritis patients, but they don't have a very clear, convincing data that actually helps. But with that being said, people who lose weight, who had bariatric surgeries, their psoriasis actually improves. So given that metabolic syndrome, one of the criteria is increased abdominal girth or obesity, that in itself can actually help improve psoriasis.
So that's like a cohort study, so the finding rather than intervention.
Correct. Yeah. It's more. A lot of the studies are retrospective, so I think we still have a lot of areas that we need to explore. So can't really say that this will help us per se. Yeah.
And for Gary, I want to ask you. You mentioned you participate in a lot of trials, and obviously for a short period of time, there are things that turn out to be good, some not so good. Yeah. How do you feel that at the end of the trial, the drugs that you found really useful help you to transform your life, no longer available to you, at least free of charge? How did that make you feel?
By the time I think, oh, there is a hope, and there is a good treatment for me and for the patients, and of course, free of charge is good, but I know it's very expensive, and I for sure I cannot afford it, so I stand up and come out to fight for other patients to try to get this drug into the drug formulary. And return to your questions, how I feel, it's really good. And to be honest, my relationship with my family is also improved. Yeah, and to be honest, I have more social interaction with friends, and we can hang out. And they also say, oh, you improved quite a lot. What are the miracles you have? Yeah, there's quite a lot of positive impact if we have proper treatment, or make it in a better way.
I think this is a very good question raised by you. It's always the questions for medical trials. Yeah, we did offer some hope and some insight of some new treatments, but very often we always have the questions: how about if it works? If it works, but after the study period, you have to stop the drugs because this is not marketed, or you do not have the fundings or resources to continue the drugs, and it's a unresolved problem yet. And this is every time, especially for biologic treatment, we did think about that as an ethical issue, but we don't have a good answer to that.
Well, I mean, for us as researchers, obviously we want to find out the answer. I just want to hear from Gary as the end user. How did they feel? And I'm very glad that he transformed this energy into something positive to be able to come out and fight for more resources from the government. But I guess there probably will be some other patients. It's like you raise their hope only to drop them from even a higher point. That could be even more damaging to some.
The way how because we also do clinical trial studies in our center, the way how we, fight for be a patient's advocate is that before the clinical trial ends, almost towards the end, we write a letter of support to the insurance company to say that patient really improves with this drug. We highly recommend that they continue or that you cover for the medication, and that usually works.
Oh, there's a positive response.
Yes,
from insurance.
but you have to the physician has to write, a strong letter of support to say, it proven to be worked. It really helped them remarkably, and we also take pictures before and after the trial to give it additional data to support them. So that usually helps them. Yes.
Yes.
We understand that psoriasis may sometimes be caused by some patients who has other form of diseases and taking some type of medications to treat them, not knowing that there are side effects. And one such type of medication may be the beta blocker for treating high blood pressure. And is there any research evidence that this form of beta blocker, for example, atenolol, they have caused the flare-up of psoriasis?
Yes, it was a good question because that's actually listed as one of the medications that can, worsen psoriasis. From my experience, we do have some complications. They're on beta blocker, but I haven't seen one that says after taking beta blocker, it actually made it worse. I think it's all relative. The ones that I have seen is people taking lithium that actually made it worse. But it's just like a risk-benefit game. If someone has bipolar disease that's really, really severe, you don't want to take them off of lithium because then they will, do anything, and not right, exactly. So you might want to. That's why when we have a patient that is complicated, we usually go hand in hand and talk to the cardiologist or talk to the psychiatrist on board and say, hey, let's have a discussion on how we can best manage this patient appropriately so that the patient can have satisfaction of the skin, but at the same we don't want to compromise their cardiovascular or psychiatric illness.
Yes, beta blocker really precipitate flares. And the other more interesting or sad story is about terbinafine, which is an antifungal drug from Fuiga for fungal nails. And this is known to be exacerbating psoriasis, even to a very unstable or life-threatening form. But the main thing is that for psoriasis, they have poor nails. They have psoriatic nails. And many times because of the lack of public education, when these patients come to the GP or come to just over-the-counter pharmacists, and they thought this is fungal nails, and you give antifungal treatments, and one of them is Japanifit, causing exacerbation of very, very severe flare of the psoriatic disease. And because I work in a hospital, I do see these cases from time to time. And I think this is probably a reflection of the lack of proper education.
I think there was a recent case reported who was taking this kind of prescription and then you.
But it's actually very common. I see these cases every 2-3 months.
And the patient passed away because of this.
Yeah. There's one, but I think that's last year. I currently got another patient in my ward.
In terms of psychosocial care and whole person treatment, maybe you can enlighten us. How does it work in your hospital? And so we can learn.
Do you have better services?
Not better service than your department. That's a good question. So in our, we actually live in a very old building. We operate in a very old building. But in our building, we do have one side of it is clinic where we see regular follow-up clinic patients. But then the other side that makes us a little bit special in some way is that we do have a treatment called Geckerman treatment. It's a Geckerman day program that only has, I think, only three location total that is available in the United States. And Geckerman treatment is basically pretty much most of the day program. You give them light when they first come in, and then tar and slather them with topical steroids, and you wrap them up with saran wrap. So when we have that, we not only treat psoriasis, but we also treat prurigo nodularis as well as eczema. And so that in itself creates a team of people, a group of people who are facing chronic inflammatory condition, and we tell them to sit in the kitchen and they'll play and they'll talk, and that in some way kind of help them to realize that they're not alone. And after the program, they actually feel very good after that. But in terms of the clinic side, where the follow-up patient is, we don't have any particular social programs where we reach out to them to learn more about their social cycle conditions. That's something we hope to have. Maybe we'll find something in the future.
How about patient groups? Do you have patient groups who can collaborate with Gary and his team?
Yeah, so in terms of patient group, we do have something called National Psoriasis Foundation that is pretty much widespread throughout the whole United States. And it's a really strong program, and patients can log into the site and they connect with all the patients who have psoriasis. And like in May, today we're fundraising for the walk. It's called Psoriasis Walk. Whatever money we get, we give it to the research, to do further research. As I think you mentioned before, genetics is a huge part right now. So they're doing more research. We're doing like skin biopsies, the genomes, genomic studies, as well as getting DNA from the saliva samples. So we have a pretty active group as a National Psoriasis Foundation, but not so much like our center, but it's like for everyone. Yeah.
Questions for Gary? Okay. Thank you for your talk. I just wanted, from a patient's point of view, what kind of psychosocial interventions that you think is most important for you, or a few of them?
Yeah. I think the most important thing is the family relations and how they deal with this with their family. How to improve the. From what I heard from patients is their family members have to spend quite a lot of time to clean up the floor, to clean up the clothes. This is one thing. This is one thing. Another thing is the patient is himself or herself is socially isolated. Their wives or husband, it's difficult to pull them out. This is another problem. And the third problem is they do not know the proper treatment. This is the third problem. Yeah. In terms of your questions, I think the social impact, how they perceive their own, is a very common phenomena among themselves. They think they their self-esteem is quite low.
So what do you think about what means that can improve all these, like counseling or just with a support group talking to each other? Which one would be more useful to you?
To patient, as a patient, I think to talk among ourselves is quite useful because we know all our past history, our feelings, and they have their common. We have our common language, and what they have experienced before, we also have, and we can share among ourselves. Yeah.
But I think public education like this already help people like me who have been ignorant about the nature and severity of the problem to sit closer to him, maybe to investigate on the MTR or things like that. But I'm also interested in, I don't know whether I've missed it, about prevention. Because in Chinese culture we think of, well, could we do something or can we give some advice to pregnant women to eat what or what, not eat what to avoid this? Is there any possibility that there is some prevention along this line?
I'm not aware of that for psoriasis.
Right. So it's hopeless to pursue along this line.
You mean for psoriatic patients who are going to get pregnant?
No. Is there any suggestions for pregnant women to eat certain things or avoid certain things just in case of, because you have siblings who are okay, and you ask why me.
Mm-hmm.
So
okay.
is it
Any kind
possible
of
to check with your
prevention,
mom? Yes, I'm talking about prevention.
I'm not aware.
Nothing. It's totally not relevant.
Yeah, it's basically interactions between genetics and also environmental factors. The genetic parts, we can alter that at this stage of medicine. But for environmental parts, you cannot do that at the time of pregnancy. But when you become a psoriatic patient, and there's some things you can try to prevent, like not drinking, and avoid some medications, avoid stress, live a happier, less stressful life, and all these could help.
But that would be to avoid a breakout or avoid a flare-up in the person who's pregnant, whether their child will be in a position genetically to express the disease or not. It's
Right, that's irrelevant.
Not relevant.
And also at that time, they are known the status of psoriasis.
Yeah.
For me, I only know I got psoriasis to 20-something. So when I was young, adolescent, I don't know. Yeah. But for one thing, we try to advise the patient not to smoke, not to do something, avoid stress. Yeah, this is the key.
But to lighten up the point a little bit, patients who are pregnant during their pregnancy, their psoriasis usually improves. It has to do with the hormones. So now, after they give birth, that's another story.
It worsens or it comes back.
That's usually the trends that we see.
And Gary, does that affect your decision in marriage or childbearing and decisions?
My wife's, we married around 10 years. We want to have children. This the skin problem. We have discussed about this, and we don't think it is a really matter here because in the future I think there is a proper treatment, and we believe okay, the skin problem is not fatal, and we will have children.
I think Hong Kong is very fortunate to have a patient that's positive and that's successful
We are
and
getting
as
more.
convincing and as Gary. And we are very grateful that you'll be leading the patient group and actually the public to learn more about this challenge and know that, well, you can be surviving and surviving very hopefully and successfully, like
Still
him.
alive.
Right. No, not just still alive, you're doing a lot, and then we have to thank you for that. And also we have to thank Dr. Lam for coming all the way from the United States and then helping us to stir up more interest in this area. Okay, and we are also delighted to have Dr. Wong and the Family Medicine Department to co-organize this with us, and also Dr. Chen from QM to. I know the two Dr. Chens are collaborating to advance our knowledge and support in this area, right? Okay, so it's very good. And thank you very much for coming. And we hope you can join some of Gary's future functions. And I think not only patients have to join your association. There should be other people who are just interested or supportive can join your association,
Yeah, sure.
and then we work together, we play together, and then we demonstrate to them that it's not an issue.
One more thing, tonight we have a TV program in the night news, 11 local. We have another patient. She got psoriasis for many years, and she will share with us her problem, and you will see her in our seminar question.
Thank you very much.
Thank you.
Yes, thank you.